I'm Smriti Khanna,
Hi, I'm Mahesh Menon.
and welcome to the first episode of the podcast Living Well.
Yes, so this is the first time we're doing something like talking to people about something that's very close to our hearts. And this is a subject related to healthcare, quality of life, and that's where the title Living Well comes in. So before I start, I would just like to ask my co host or the host of this podcast, Dr. Smriti, what comes to your mind when you think of living well?
Oh, interesting. When I think of living well, at least from a health perspective, I will think about being free of disease, not having disease, being healthy, being able to do the things that I want to do, uh, and in the context of what living well means if I am ill or if I do fall sick, then what how I can feel better most of the time, and how I can do the things that I love to do for most of the time.
Yes, and was it always this way where like when you entered medical school and did you have this concept? Do you think that once you enter medicine your idea of living well changes from when you're not in medicine?
Absolutely, absolutely. Because, I mean, it's like your medical college is a closed group, right? Because you will see, I mean, ever since you start your ward rounds in medical college, you will see a lot of people with illness, a lot of people with disease around you. And suddenly, health becomes very important. Suddenly, it's almost like you walk into wards every day and you are just filled with gratitude that you are able to walk and talk and eat the way that you want. And there are people around you who cannot do things the way that they want, or who cannot, who are struggling with basic things. So my background is that uh, I got into MBBS because it was the family profession,
That's right.
and got into MD because general medicine or internal medicine is what I've always liked to do. Again, it's the family profession. Went through a lot of super specialities before deciding that none of them really appealed to me, and then I finally chose palliative care.
That's right. So if there's a medical student out there who's listening to this and they hear these two doctors talking about palliative care, they hear your journey that you went from medicine, you specialized, you super specialized, and you chose palliative care. Although as though is like the fourth level of specialization. And what made you do this? Because you have so many opportunities. You can take other professions as well. What brings you here to this point where you choose palliative care?
So we've kind of let the cat out of the box because we have let everybody know that living well is actually about palliative care, which is something that is close to our hearts.
Because
And
we work in palliative
we
care,
work in
we and
palliative care,
chronic
and we
pain.
will
Yeah,
get to
yeah.
your journey also
Oh, we
eventually.
must. That's what's the point of asking you all of this.
Exactly,
And yeah,
exactly. I know. Pata hai. So, what got me to get into palliative care was that, first of all, context on palliative care is that it's a less frequently chosen subject for a super specialty, for a subspecialty. Palliative care as a field is relatively new in India, newer than a lot of the other established fields. And so, as a corollary, not many hospitals have palliative care.
correct.
I was lucky in that the hospital where I did my MD actually had a palliative care team.
Oh, so you
And
had
so
exposure
I
to.
had exposure. I saw firsthand what it meant. I saw the focus on pain relief. I saw the focus on quality of life. I saw that it was important that all patients, all people, irrespective of the stage of the illness that they are in, deserve quality health care, deserve non-abandonment by their doctors, by the healthcare system. And this, I think, stayed in my mind, kind of dormant, like it was kind of just like this knowledge was there in my mind, and I knew about it, but I didn't do anything about it because I finished MD. I said, okay, I want to work in nephrology. I did that for a few months. I said, okay, I want to work in the ICU because that's a glamorous field. I did that for a year. I said, okay, I want to work in hematology and oncology because that's also a glamorous field. And I went and worked into that for 2 years. And at the end of all these years, I felt like something is not clicking. And it was a random conversation with my parents in Lucknow, where we were doing our where my husband and I were doing our residency, where we I suddenly remembered, okay, maybe I want to go back and see what palliative care is like. Maybe I want to just go and explore that.
Because that's one thing that you hadn't explored. You've done all the, yeah.
Exactly, because I took a roundabout way, I took my way, I took my time with it, and I explored quite a few fields before saying, okay, maybe this is one that I want to do, this is one that I want to explore. And that kind of opened up this whole new world. It was a difficult journey at the beginning, but right now it's been 5 years into it, and I'm so glad that
That you
I
took it,
did
yeah.
that I had that conversation.
Yeah. And interestingly, I see that you, even in palliative care, you entered, I'm not sure if you entered at a subspecialty of palliative medicine. You entered in pediatric palliative, which is by far one of the more difficult branches to deal with and more comprehensive. So, what made you go into pediatric palliative? Of what made you start with a subspecialty?
That was sheer chance, da, because when I did a short training in palliative care in Kerala, which is kind of like it's the motherboard of palliative care in the country.
That's right.
It's where it has all started. And so I did my short training there, came back to Bombay, and just started looking for jobs and just started looking for
That's
opportunities.
right.
uh, I have always worked in institutions, and so that pull of institutions has always been there. And so when I found that there was an institution that wanted to start a pediatric palliative care unit, and I went there and I worked with them, and I liked the work, and they liked me, and then it was a good fit, and so I chose pediatric palliative care. The wonder that the wonderful thing about it was that the work that I did as a team, which is not something you don't always see a lot of teams in healthcare, a
In
lot of
healthcare.
teams working seamlessly the way that
That's right.
this worked, and it was jackpot for me.
Yeah. So something that you said very again a beautiful thing, because the days of individual brilliance, where people would
Mm.
manage that with that flamboyance, and I know it,
Yeah,
and
yeah,
that those days, because there's so much knowledge now that in order to be in the same place, you have to keep running now, because that's the kind of
yeah,
information overload we are
yeah,
getting in medicine.
yeah. Correct,
And it's not one person who can deal with all dimensions of disease.
correct.
I mean, hats off to all the super specialists out there who deal with each and every case with, on the scientific merits of it. But when it comes to going beyond that, when you're dealing with people in medicine, when you're dealing with people and real life experiences, the bandwidth that you require is so much more.
Mm.
And it's as you rightly said, it's something that is not there. You don't get to see it, and it's such a rare
Yeah,
thing, and
yeah,
that gives you that beautiful opportunity to come in and take that field
yeah.
forward. Absolutely.
Absolutely, absolutely. um so I think that was a little bit about my journey into palliative care, but I also want to know about when did you first hear about palliative care and
So good point. So when I was born, the gynecologist who delivered me, he told my mother कि palliative care physician पैदा हुआ है. So I was like born like this. We'll go on to the next question now.
yes.
Yes. So, but I'll tell you my journey in the sense it's interesting because Smriti, you mentioned that you had the background, you've been in a family of doctors. So when I became a doctor, my family has PhDs.
Hmm.
When I became a doctor, it's my parents never came to my medical college. They never came and visited me in medical school, or they didn't even know where my medical college is. Once I remember my mother twisted her ankle and then she came and that's when she saw the medical college. And one of my aunts came in and she said, we have to go to his college. We have to see, because they wanted to see me in that white
White
apron.
coat.
So I wasn't sure what this intense attraction and respect, suddenly that you get.
Yeah.
But for all those
Yeah.
people, especially medical students who will be watching this, so I'm like the first doctor in my family in the village that my parents are from. And it's so surprising that there's the first doctor and medical doctor that is. So it's such a big aura, and that I didn't know that there's so much pressure on me. And I was disillusioned with the medical system, because the first thing I decided after passing out from, I did finish my MBBS, I decided I'll do what I love to do, which is family practice. So I started my family practice, and then I wanted to be a neurosurgeon. So I said, if I want to be a neurosurgeon, I need to see what neurosurgery is like. So I went to Sion Hospital. I just walked into the head of department's room. He was very sweet. And he told me that, look, we have a shortage. So we will get you with some terms and conditions, but we'll make you work in the department where I published a few papers. And I worked there. I would work from 6 in the morning to 1 o'clock or 2 o'clock at night every day. I would just get to go home, and that was the only advantage. And I didn't really know what value it added, but it gave me a feeling that I'm not 24 hours in the
24/7,
hospital. Yeah, so I would do that. So I did 6 months of neurosurgery. I did small procedures like putting in ventricular drains, that's putting tubes into brains and getting fluid out when it's blocked, and doing fancy stuff. And then I realized that I need people to talk to me. I would rather not have people who don't talk to me.
Someone on the operating table will not
talk to me. Or I'll be disturbed if they do.
Yes.
So after that, I did a family practice stint. I went back to family practice. I was there for a year or so. And then I felt I needed to do something else. So I took up a post in pathology, which is a non-clinical branch. So I was working in a blood bank. I was looking at blood smears. I was looking for malaria parasites. I was picking up blood cancers on the slides, the old school method of looking at it or things.
Yeah.
And I was lucky to work in a beautiful hospital in Bandra, and it overlooked the sea, and it was very pleasant, and it's a great time in my life. I had taken the US medical licensing exam and multiple things. As things went, very meandering. And then I took all India entrances. I got into AIMS, I got PGI, I got a few other places. I said, I don't want to do all of this. I had decided I want to do medicine or pediatrics, and that's what I would like to do. Because of that, when I took All India, I got a rank, and I said, look, my ranks are dropping every time I'm taking these entrances. So I got AIMS, then I got PGI. I left those seats. And it's like that story in the Panchatantra about that man who has that wheel on his head. And I said, if I take the next one, I'm going to get a lower rank. I said, I'll take whatever I get. So I took up anesthesia, paradoxically, where people again don't talk to you. I said, what am I doing here? So I took up anesthesia in a fantastic institution. I had 3 best years of my life there. And I distinctly remember one instance. And I remember it because as we speak right now, I can still remember the person who was in pain with a fracture, and I'd given him a nerve block. So we inject the nerves that supply the limb, and I gave a nerve block with anesthesia, which reduced the pain of his fracture immediately. And this man is crying and shouting on table. I do the injection, and I could see his face. I could see the pain leave. And that hit me. It was like love at first sight. I said, this is what I want to do in my life.
Wonderful.
Some way or the other, I want to be that person who's there when this happens. Then I said, brilliant. And again, I'm in anesthesia, so I have to make sure that they fall asleep. So I'm missing all the glamour, I'm missing all the validation. I said, no, I need to keep them awake. So I started looking at where anesthesia goes. And there were 4 or 5 disciplines that I could do when it went out of, when you finish anesthesia. And I'm a gold medalist in anesthesia. And all of that. So I said, I have a lot of choices now. So I don't know what to do. Then I took up pain management because I met someone who's very interesting, and she used to work with Tata Memorial before, and then she started her own practice. She's one of the pioneers in pain management. Her name is Dr. Lakshmi Vas, and she has a clinic in Bombay, and she was working there, and it was a private sector workout. Yeah. Because I didn't find any organizations that are willing to take me as a pain specialist or train me in pain. There was no training
There's no
opportunities.
training in. So it is like from family practice to neurosurgery to anesthesia, family practice back to anesthesia, and now to pain.
Pain.
Yeah.
And once that phase got over, I said, I need to step up my game. I don't think I am ready to go out into private practice all of just my early 30s, and just not even 30, and I want to go into private practice and tell people that I'm a specialist, because there's no training opportunity in India. So I got a
So you
fellowship
have to
from
have
Singapore,
something. Yeah.
and I met someone at a conference in Hong Kong. And me being me, I was showing someone a procedure of one of the blocks that I would do. And this person happened to be someone who knew the director of the program. So she said, would you be interested in training overseas? I said, yes, I would love to. And she said, okay, I know somebody, I will recommend you because I've seen what you do, and I'm impressed. I was like, sure, you can put in a word. And I was so happy. And I had applied, and I got my approval like immediately, whereas the waiting time was quite a bit
Got
then.
it.
So I was very lucky. I always consider that I've met the right people at the right time in my life, and there's been a lot of helping hands, so you reach somewhere. And I did my fellowship, I came back to India, and I was supposed to join a hospital. And when I came back to India, I call up the director of that hospital and I said that, look, I'm back. Let's do this. He said, I left the hospital already. And I'm like, oh my God, now who do I go to? And then I got a call from another organization, Kokilabhen Ambani Hospital, which was setting up oncology, and they were interested. They were very young into their establishment, and they called me after 2 or 3 years of having set things up when they realized that there's a need for pain management.
Yeah. Yeah.
Then I went there, and
Something that not a lot of hospitals have found, like felt that need.
I guess hospitals who talk to their doctors are able to get the best
To
in science,
understand.
to understand what
Yeah.
the science wants.
Yeah.
Because there are two elements, and rightly so, because people feel that hospitals are a place where a lot of money is made, or people make money, which is true, because it's a paid for service, it's a commercial establishment. But at the same time, the the ability to deliver some services can be really very good if it is backed by financial power.
Yeah. And by like sound knowledge.
Absolutely. So
Yeah.
to make things available, to make those things available, to deliver those things, you may need things. It comes in parallel with our public health system. When our public health system is working, it's already overburdened, and you need a sort of decompression area where you can deal with this. Otherwise, we'd probably face situations where the affluent people would anyway leave the country, fly off, and go and take this treatment elsewhere. Instead, if they get it done here, we can get people to come here, like medical tourism does, and get those services. Again, it's good for the country.
So we are
So,
going into public-private, but let's get back to your
the
chronic
hospital
pain journey.
yeah. So that I started this, and when I was working with thanks for bringing that back. Because I was working in chronic pain, I realized that the pain part is easy to manage.
Huh.
And for me, it was
For you, it's
relatively
easy to
because
manage.
it's something
It's not
that
something that everybody does, but still.
but so I was very confident of managing physical pain, and then it just about brought me back memories of my home visits and the things that I used to do as a family physician, where the suffering element is still not addressed. So I said I would need to do a bit more in palliative medicine. I had been to Kerala. We had done a home visit with Dr. Rajgopal's team. They were going around in the Maruti Omnis and taking care of people.
Yeah.
So we had done that in 2008 or 2009. It's about 15, 16 years back. And I was very impressed with this concept of this man from Kerala who's setting up something. And it is like watching their life unfold in front of your eyes, like the things that they are doing. I can't say I saw him grow in front of my eyes. Of course, he's already grown. But it's so interesting to watch
No, to
growth,
see,
even that
like from close and from far away.
far away. And I was very happy that I went there, because I think I was doing something right. At least I was able to
Correct.
identify this is where good work is happening.
So this is your journey from chronic pain to palliative,
Palliative
care.
care.
Or rather, we could say from pain to chronic pain to palliative care.
Right.
Because this is something very interesting about pain, which I found very interesting when I started reading it, is that pain is actually supposed to be a marker of some injury, something going wrong somewhere in your body.
That's right.
And usually acute pain or pain that happens like quickly is that. But chronic pain is a whole other ball game.
Hmm.
Chronic pain is when the actual insult or the injury has long gone and now your body is just feeling pain.
That's right.
It's very strange because your body is not supposed to do that to you, right? Like if there is something wrong, it's supposed to give you
Yeah.
like a warning that, you know, SOS, kuch to gadbad hai. And chronic pain is something that stays even when what is wrong has
Gone. Yeah.
long gone. And so chronic pain, in effect, is useless. It doesn't have a function. But you live with something that is very distressing for a very long period of time. That's why you call it chronic.
Chronic pain. Yeah.
And literally, it can change the way you think because you are living with something that's both distressing and of no use to you or your body at the same time. And how much of a burden that must be, how much of a psychological burden that must be.
Absolutely. Yeah.
And so that then means that chronic pain comes with its own psychological burden, its own suffering, and
That's right.
that's where palliative care comes in.
Yes. So you actually hit the nail on the head when you said that acute pain is something that subserves a protective function. It informs you that there is damage to your body and you take action. After a point of time, that signal gets embedded into your system software and you're fine and you still have pain. So I have had to see people who have been very disappointed. As recently as yesterday evening in my OPD, someone comes to me and says, "Doctor, all my tests are normal." And they were so disappointed because all their tests
Kuch
are
to
normal.
hona chahiye na? Why is
Exactly.
this happening?
Because
It's trauma. Chronic pain is your body experiencing trauma in the long term.
So because of this approach, I realized that if I'm getting rid of the pain part, the acute elements of pain, and looking at the chronic elements, getting people back to recovery, I'm able to do that in a lot of non-cancer conditions. Why am I not able to do it in cancer conditions as often as I was doing in non-cancer? So I went into palliative medicine and I started developing it. I realized that you need a team to deliver palliative care. Medicine I can do, care all of us have to. So then I started building up a team, and I was very fortunate to be backed by people in the organization at that time.
Priya, who we will
Like
be
Priya,
interviewing.
who we will yeah. So all of that made a huge impact on how we will set up palliative medicine services. Cut to 10 years of doing palliative medicine, working all across Bombay, interacting and meeting very impressive people in the world of palliative medicine. So you're also going to give me a compliment later because this is how it works. Yeah, this is how it works.
Yeah,
Scratch. Yeah. So when we interacted with people, understood that this is the world of palliative medicine, I felt I need to step out and do something more than what I'm doing already. And that's when I was again fortunate to get an offer from Bahrain because they had just set up their National Cancer Center and they wanted to expand on palliative care. Whole new country, whole new culture, don't know the language, don't know the food habits. I don't even know where Bahrain is. So one of my friends said the first thing he did when he got an offer from Bahrain was went onto the map and he magnified 4 times and then he saw the country. And it's a strategically placed country and one of the most wonderful people I have met. There's something about islands. I was in Singapore. I fell in love with the place. I was in Bahrain. I fell in love with the place and the
Bombay
people.
And also an island, by the way.
And Bombay is an island, yes. So I see something about islands. So amazing experience. And we set up a fully functional palliative service in the National Oncology Center.
Brilliant.
And was backed by the defense. So there was a lot of initiative. And I felt that wherever there are people who are willing to put their weight behind you, it just amplifies the kind of work you want to do. So you're not no longer swimming upstream, you know.
Yeah.
So that made a huge difference. That's how I went into palliative medicine. And right now I'm working all over the city. I've come back. I'm working all over the city and,
Welcome back.
Thank you. And that's where, I think what I wanted to ask you next was, remember you said something about the public and private that I was digressing. But it had occupied my mind when you had initially made that introduction because I wanted to ask you that you worked in a public space.
Public hospital.
Yes. And from that public hospital space, you moved to a private organization. what is the difference in this, uh, in the way they manage palliative care, or in the way they manage quality of life in a public
So
hospital and private hospital?
uh, things are different, but things are still the same, is what I would say. Because health, disease, suffering is something that happens to all of us. Uh, what India lacks for, with with the absence of like a nationalized health service, or a paid for health service, it makes up for in the amount of diversity and the amount of kind of enthusiasm, rigor that we have, from people, from institutions who want to be able to make people's lives better.
That's right.
So all most of the institutions, like if we compare your medical journey and my medical, a lot of the institutions that you and I have been to are public institutions.
Correct.
That's where we have learned most of our things.
That's
That,
right.
like, those are the institutions that we owe our medical knowledge to,
Absolutely.
our
No.
like ability to deal with the masses, the numbers of patients at a time. uh, and so, really, I think that public health institutions have formed the backbone of our country. They still are. Because I speak to my friends in public health and I see that there is so much still going on grassroots level. We talk about PHCs, or primary health centers, so disparagingly, but there is so much that is being done there. There are so many good people that are really motivated to do good by their
Yeah.
community, or by the people, for the people around them, and they are doing some excellent work. And so, um, yes, we have the public health background. We then have the private or the corporate space, which is something that has mushroomed newly. Maybe,
That's right.
looking at or finding inspiration from private health institutions around the world. These are also well established, centers of excellence in their own right.
That's right.
Because a lot of it, even if there is a plan of making money behind it, as you said, a lot of it, there is a lot of goodwill, there is a lot of good work, a lot of hard work, a lot of inspiration that people behind it have put together. They want that the institution that they build is good, is not even good, it's great.
That's right.
So what we have been blessed with throughout in this country has been like amazing individuals and organizations. At the end of the day, it's people, right? Like, if like when I speak to you, I see the motive, what motivates you to take care of patients, and I see maybe the empathy that you have in you, or maybe what you call the humanity that you have in you, that really makes you want to reduce somebody else's suffering. That was your compliment, by the way.
Oh, that's the mandatory compliment part. Yeah. Okay.
But uh, there are many people like you.
That's
There
right.
are many people, there are many organizations like you who have this at the background. And whether money is involved or not is not really part of the question here.
Yeah, they would have found some way to do
They
that.
would have found some way
Some
to
way to
do
do
that,
that.
even if they did not have probably the money.
Absolutely. So you make that difference around you, and that's
Yeah,
who they are as
yeah,
people.
yeah. And so we have this public and this private sector. We then have the non-governmental or the NGOs.
That's another space.
That's
Yeah. So
another
the third
space.
model.
That's another model, another healthcare model that adds on to this. We have what is known as the trust hospitals. We have so many trust hospitals in India, all
That's
over,
right. That's right.
wherever you go. We had a lot of missionary hospitals. There aren't too many new ones coming up, but still the old ones are working
Working.
amazingly well. So there are so many. See, healthcare in India is a lacuna that so many people and organizations are trying to fill.
Uh, Whenever I've worked in the private space,
Huh.
I have seen a lot of people and
Hmm.
their families come back to us and
Yes.
ask how they can contribute or how they
Yes.
can give.
Give
Is there
back.
something I can do?
Yeah. Yeah.
And
Yeah.
and the best part is they may or they may not do it, but the very fact is it strikes a chord that whenever we talk about living well, whenever we talk about quality of life, people immediately relate to it.
And they get it.
They get it. It's, you don't have to make an effort.
You may not need to say the word palliative care to say the
Absolutely.
phrase. You may not need to say living well. You may not need to say what call. But everybody intrinsically gets
They
it.
get it. And they want to show up. They want to come
Yeah.
there, and they want to. So
Yeah.
there's a lot of untapped potential in our community, that there are a lot of people out there, doctors. In fact, interestingly, I speak to a few doctors and they ask me, what is it that you're doing, and how can we help? Or I know somebody who's doing something, and they share contacts. So there's so much work that's happening potentially with
Potential. So, a lot of times I meet people who, or doctors rather, who, when they ask me what I'm doing and I say I'm doing palliative care, and they are, quite surprised, sometimes impressed by the idea. I've heard quite a few people say that, okay, I'm in my XYZ practice right now, but at the end of my practice, it could be private, it could be in a public institute, I want to quit and still keep doing something for the community, social service,
That's
or
right. That's
just
right.
giving back to the community. And maybe palliative care is a way to do that. Now, there is some amount of fallacy in that, because what you're trying to say is palliative care is something that you do only towards the fag end of your professional life,
Profession, or yeah.
which is not true. But what it means is that every doctor, like, this is the spin that I would like to take on it, that every doctor, irrespective of what specialty it is they're doing, whether it's a glamorous job, a surgeon, a physician, an intensivist, they understand what it means
Yes.
to
I think-
enhance quality of life.
So I have a feeling that nowadays we talk a lot, when you mentioned that, the private space is coming up with it, with NABH and so on, which is the accrediting body that tells you that you need to have a department of palliative care, you need to have policies in place. But I feel it's linked with the concept of value addition to human life that happens in hospitals. And each and every private hospital that comes up is now trying to look at how can they add more value, how can they tell that they are more compassionate. Even this competition is actually good competition, because you're competing to be good. You're competing to be better. You just don't want to have the most fancy high-tech equipment. You want to be seen, and you want to be known that as compassionate people.
Yeah.
You want to be known as an organization that values human life, and you're willing to put your money where your mouth is. You're like, yes,
Yeah.
I'm going to invest in it.
Yeah.
I'm going to make it happen.
Yeah.
So this was the first part that I observed. And the second part that I had observed, that in private hospitals, people paradoxically who had access to healthcare may have access to a lot of treatments that can help with curing their problems, but they don't have access to pain relief. They don't have access to palliative care. And when they come to us, they come from a point of very bad quality of life. And when they come to us, one of the first things they ask is, why wasn't I told about you before?
This before. Yeah.
I mean, I have. Why should I hear it from the internet or from my relatives sitting overseas? Why should I hear it from a doctor in the UK that I need palliative care?
Yeah.
And so
Yeah.
on. So, what are the misconceptions? One of the misconceptions that you mentioned was the concept that you can do palliative care as a branch, like more like social service at the end of life or at the end of your career. So there are two myths. One is related to the people who you're serving, and one is the people who want to serve. The people who want to serve say we'll do it at the end of our career, and the people who are being served are assuming it's only end of life.
End of life.
So what are the, in your experience, in your journey from your undergraduate days or your postgraduate days when you had exposure to palliative medicine, and today, what are the misconceptions that you have encountered in palliative medicine?
So, one of the commonest misconceptions is that palliative care is for those people at the end of life.
Yeah,
Last few hours, days of their life.
That's right.
Which is absolutely wrong, because quality of life means quality of all your life, right? You can start palliative care at any point of time in your disease trajectory. One other misconception that I've seen a lot is that it's only for cancer. It's only for people with cancer.
That's right.
And cancer actually forms a small part of patients that can be benefited from palliative
About
care.
30% of
20-30%, correct.
Yeah.
Chronic neurological diseases, stroke, bedridden patients,
Renal,
failure
kidney
of
diseases.
all
Yeah.
organs in the body, kidney, lungs, liver, heart, any of that. All these patients will benefit from improving their quality of life. Mm, so these are some of the few myths. Some other myths that I faced is that, okay, things like cancer pain is something that you just have to bear. You have to just grin and bear it
Bear it. Yeah.
for the remainder of your
That's
life.
right. Yeah.
And people, there are so many myths around cancer pain. I'm sure you must have come across a lot of this.
So there's a lot of myths in medicine. There are
Huh.
a lot of myths in cancer. There are a lot of myths in different types of cancer treatment.
Hmm.
There are a lot of myths in palliative medicine.
Hmm.
So the amount of mis and disinformation and lack of information out there is stunning.
Stunning.
You may have the best internet speed, but you may not have access to a lot of good quality information, like I said.
So, we have kind of jumped the gun without either of us talking about what we feel palliative care is.
That's a good point, yeah. So if you
So, you start. You
yeah,
tell
this is a
me
good point.
what's
So
your
we
definition.
had an entire conversation about palliative care and other things in our journeys, but we didn't talk about what we feel or what we know about
What
it.
we,
Yeah,
yeah,
exactly.
exactly.
So for me, palliative medicine deals with something that helps people with quality of life. And in the same way, I think that the boundary between what I do in chronic pain and palliative care is blurred because
Yeah.
again, I deal with quality of life. And when I see that I'm trying to make people happy at the end of the day in the medical field who suffer from illnesses which otherwise would definitely not make them in a happy place, keep them in a happy place. You can see it. So there's a
Hmm.
beautiful line that I read in a pain textbook. It says chronic pain is like beauty.
Hmm.
You can't describe it, but you know it when you see it. So the same thing with palliative medicine, that you know that someone is suffering. And if you can sense that with a serious disease, then it is incumbent upon you to kind of help that particular person. And that may be a disease with a short out lifespan or a long lifespan, or they are undergoing treatment. So for me, the overlap was there. So I look at palliative care in this context, that wherever there is suffering in the journey, treatment journey, or the suffering extends to the family members. And this is
Hmm.
something I learned.
Hmm.
This is
Hmm.
something that I learned. This is something that I
That
hadn't
one person suffers means a entire family
family.
suffers.
Yes, yes. So this is something that I learned. And I remember these instances where we come across people who bring these fantastic stories to us, and some of the concepts and how the paradigms that changed in my mind. When I was training and I was in early days, I would hear a lot of senior palliative consultants in the country, teachers, tell
Huh.
us that for death, home is the best place. You should
Yeah.
always.
Yeah.
And I was like, yes, and I would like, home is the place. And then I met this lady who told me, doctor, we have insurance.
Hmm.
My husband is terminal.
Hmm.
I have a 1 bedroom hall kitchen.
Hmm.
If I take him home, insurance won't cover his expenses.
Costs. Hmm.
I'm working. I'm going to be the only person earning in the family. I have 2 children to take care of. I've got his parents who are old. We're all living in the same place. And we're going to have relatives coming in, which
Hmm.
means culturally we have to offer something to them. Even if they
Hmm.
come to ask about someone who's very ill,
Hmm.
there's a lot of work
Lot of
that
thing
that
around.
she
Yeah.
has to do. She has to actually cook for them. She has to
Hmm.
give them a cup of tea. It still is a lot of work. She says, here I can just tell them that the security isn't allowing me.
Hmm. Hmm. Hmm.
Here I have access. I can control and I can spend quality time with my
With him.
husband.
Yeah.
And that told me that it's so personalized.
Hmm.
And for me, that's what palliative care is. Although the term palliate means to cloak or to cover or to mask, and the movement started somewhere in the 60s or 70s. But I feel that it was at that point of time, with the amount of information they had in medicine, it's something that evolved today. Now, today, and even in the last 10 to 15 years that I've been seeing things, people are living longer. There's so much
Yeah.
survivorship.
Yeah. Yeah.
And palliative care can make a huge difference. There's this young man who had come from Madhya Pradesh. He had radiation for his throat cancer, and radiation causes ulcers. So he had severe ulcers and pain, and the family got him to me saying that He's just wanting to catch the next flight and go back.
Hmm.
He says, I don't want to take treatment. It's enough.
Hmm.
And I said, it's okay. That's your wish. But I'm here to do my job. I'll take care of your pain. I gave him medicines. I managed his pain. He didn't show up after that. So I assumed he's gone. He's abandoned his treatment and he's dropped out of cancer treatment, resigned himself to the fact that he's going to die of the disease.
Damn.
3 weeks later, the family walks into my OPD and he's standing there and grinning ear to ear. He says, the pain went away. I finished all my radiation. And that radiation was curative for him. He's surviving. So it's a small, I wouldn't say it's a small difference it made. It's a huge
There's huge
difference
difference that
that it
made.
makes.
Yeah, yeah.
And that's the impact that rightly timed medicine can do. It's just that it's a missed branch because you're focusing. And again, I've started using this line that I tell people that when I'm teaching, I said that we are the reverse Dronacharyas. Like we don't tell Arjun to look at the eye of the bird. We ask Arjun to look at the bird.
Everything.
Look at everything.
The
I
bird,
want you to
the
see the bird.
tree,
Look at the tree.
yeah,
Look at
yeah,
everyone
look
around.
at everything.
So we're the
No,
reverse.
I liked that bit. And see, this is, you are just treating a person with cancer or cancer, related side effects. You're treating that pain. But any person's experience of the disease or what they are going through is equally important. So even if at the end of this, say this man was persuaded by his family to still continue radiation without any pain medication, he would have still survived, he
still
would
done
have
it, yeah.
still done it, but with what
So much suffering.
experience,
And
so much suffering, and
Absolutely,
that would have
absolutely.
then had a negative impact on him if he needed to take treatment at any point of time later on in the future.
Absolutely.
His family who had seen him going through so much pain and suffering, it's a terrifying prospect to see
Absolutely.
somebody
So-
go through so much pain.
one of the reasons I personally feel that conditions like cancer or advanced medical illnesses or even medicine in India faces all this misinformation, disinformation is because there's a lot of quality of life suffering. People are not living well with diseases.
Yes,
And
yes.
that kind of colors people's experiences about medicines. They say, all right, so we're going to take recourse to maybe alternate treatments,
Therapies.
which is good. It should complement, it should go hand in hand, things should work together. But rather than looking at the science and the methodical way of addressing things, people just tend to take a path of least resistance and they
Yeah,
are not willing to
yeah.
put in that
Least painful,
least
least.
that's natural, isn't it?
Yeah,
Like
yeah.
you drop out of journeys.
Yeah.
So that for me kind of highlights where a lot of misinformation about diseases and palliative medicine comes from. What do you think of palliative care?
Yeah, this bit that you said about personalized medicine, for me, palliative care is personalized medicine. When we were studying MBBS, or when I was studying MBBS, when they used to talk about personalized medicine, they would talk about genes, gene therapy, going
That's
into
right.
your cells and checking which gene do you have, and then giving you medication specifically for that. While we are doing a lot of progress in that area, we are still, like, years away from a lot of breakthroughs. But to me, palliative care is the epitome of personalized medicine, because uh, it just puts me or anybody who's ill back into the driver's seat. You spoke about so many chronic diseases nowadays, people living with them and living not well with them. So the experience of living with the chronic disease is different. And unfortunately, in medicine, we have at some point reached this place where our focus is on the disease and not on the person who actually has the disease.
Absolutely.
And so palliative care is like, and so that means that the disease is and so that means that the disease is in the front seat, the disease is in the driver's seat. Palliative care is bringing the person back into the seat, because what are you
Yeah.
trying to do? You're just trying to make a person feel better by curing an illness, right? And that's what palliative care puts emphasis on. It says that, get your focus back to the person, ask him or her, ask them, how would how are they feeling,
Feeling and what do they
how are
want?
they
Yeah.
suffering, what do they want, what are their preferences, do they want to be on a ventilator at the age of 80, 85, 90, do they want to be in an ICU, do they want to spend their last days with loved ones around them or on a machine with things beeping around them. It's not so cut and dry, but the ability to
The power of choice,
the
you mean?
power of choice, the power of autonomy, what are our medical
Mentally,
ethics which we learn, the putting autonomy back into the person's hand. As doctors we are taught so much about absolutes, no, like
oh yeah,
this
yeah, yeah.
disease, 7 days of this treatment, 3 days of this treatment, and that's
Yeah, it's a
it.
bit like Baman Irani from Munna bhai MBBS, when he talks about it. And the movie was such a hit because that movie dealt with living well and a
Mm.
quality of life and things like that. And there's this guy who focuses on disease. And so people get it.
People get it because uh, I don't know about the statistics of this, but a lot of doctors that I know say that they will never go on a ventilator.
But it's true. They did a study in the US
Hmm.
and they interviewed doctors who had advanced diseases themselves. And the vast majority had decided that when it came for them to go, or their time had come and they were dealing with a disease which had no cure available, they would prefer to pack up, spend
Hmm.
time with their family rather than enter the medical system, which is a cure based system. And they would focus more on palliative and supportive care. So it is proven that
Yeah.
doctors take that choice.
Yeah.
But with
Yeah.
autonomy, uh, I'm reminded of a small anecdote that it's a small thing that happened with me. I was in the hospital and there was this lady who was very afraid to do anything. She didn't like to take chemo. Her family had forced her. She didn't like a lot of things. So when she came to my OPD and she was in pain, so I was managing her pain, and I told her this, that look, you are the boss and we will listen to you. And that's the line that I always used to tell her. Whenever we would meet, I would tell her, you are the boss, you are the one who has the choice, and you will make those decisions. And she was like very happy with it. She would always be happy because I was the only person who would tell her that
Who would tell her that?
you have to make that decision. I wouldn't tell her you do this. Then once I remember writing a medicine for her, I'll write this medicine, and she started making a face, that I know she would have taken it. Had I just said it and typed it and told her to take it, she would have. She started doing that. I said, you don't want it? She says, she shakes her head. She says no. And then I say, okay, you are the boss. We're not going to give it to you. Now cut to about a year and a half later when she's really sick and she's hospitalized, and the ICU team has come in and we have all seen that the cancer has spread,
Hmm.
and she doesn't have maybe more than a few days left. Now she's on the bed, and the nurses are trying to poke and prick and give her injections, and she's grimacing. She's has very little energy. She's very weak, and she's not communicating now. And the family says that the only time she makes any reaction is when people try to do injections for her. Then she just winces, she grimaces, she's not comfortable. So I was on leave, so I joined and I came back and I saw her and I was trying to manage her pain. So I started managing her pain. I made sure that a lot of things were not being done which could cause her pain.
Hmm.
And then her husband said, Doctor, should we do something more aggressive than this? So I said, we've had this discussion where she had always said that she doesn't want it. Look, now she's at least comfortable. She's not in pain. She's not wincing. She wasn't talking to you 2 days back. She's not talking to you now.
Hmm.
But at least she's not shouting, screaming, and wincing because this is a very advanced disease. And so I put my hand on her head and I said, remember, and I always talk to her. I would never talk about her. I would still talk to her. Like I would always ensure that she's part of the conversation. I don't know how much she's getting, but I would still ensure that. So I would tell her, remember, who's the boss? It's you, right? And I looked at the husband's face. His face had lit up and his eyes were wide open. I didn't know what's happening. And then I looked at her. That woman was smiling. She was smiling. She died 12 hours later. And that family came back to thank me, saying that, Doctor, in the last 72 hours of her life, where she had only grimaced and made noises with pain, we remember that she smiled and she was happy. And that makes
Amazing.
a huge difference. That memory of someone dying well is something that
Yeah.
that family will talk about
Yeah.
for the next 1 or 2 generations. I mean, that will, at
Absolutely.
least, I'm sure it'll outlast
At
me.
least our grandchildren.
At least it'll outlast us, So the point is that
I
there's
mean,
so much we can do.
we remember how our
Absolutely.
grandparents passed away, right? And we think about it so many times. Like we hardly ever talk about it, but we think about it so many times. And some, I am filled with gratitude that my grandparents, both my grandmothers passed away at home peacefully. We were all around. You remember that with so much gratitude. I can still remember her hand on my cheek.
Yeah, they lived well.
Minutes before she passed away, I can remember
Absolutely.
that. And that is the lasting memory that I will have of her.
And also of healthcare.
And of
This is what
healthcare.
healthcare can do.
This is what,
It
yes.
need not be drama and
Yeah,
action and
yeah,
violence and
yeah,
suffering, and
yeah,
it
yeah.
can be peaceful, it can be smooth, it can be planned, and you can prepare for it. Of course, there are the beauty of healthcare. As an anesthetist, I used to work in the ICU. That's one of the career trajectories I could take. And we have resuscitated people. We have worked with people with extreme disasters, and really saved lives. And
Yeah,
it's a different high. And that's the
yeah.
beauty of medicine, that it has a range,
It has a range.
but we want to make sure that everyone
Everyone has to be covered.
covered, and everyone has to live in the right way with less suffering and minimize all of that. So now that we've discussed so much about palliative care and we've spoken about our journeys and where we are, do you think that there's a career opportunity in palliative medicine? If those who take their postgraduate exams and they come in, is there an opportunity for them in this field?
Absolutely. There is. The need is immense. Uh, it's multifaceted. There are so many things that you can do as an individual or as a team. You can build a team as you go. You can you can have different roles. I've been practicing palliative care for adults, for children, for cancer, for non-cancer, in an NGO, in a public hospital, in a private. So that means that there is literally a
There's
lot
a
of
lot of job.
opportunity out there, and it's only going to increase. This is something that we have always seen with any medical specialty. When it starts small, the niche always broadens. More and more people rush to fill it.
Exactly.
So in a way, palliative care, if there is somebody out there who's planning to do the MD or who's planning to get into palliative care, I would say you're at the right
Right
time,
time.
because you are ahead of the crowd here.
I got a call for a person with a disease day before yesterday, very educated family, and they asked me what is it that I do, and I explained that this is what I'm going to do. The man who's made the reference, who's talking to me about his mother who's suffering from a disease, he pauses for some time. He says, "Doctor Saab, my daughter is studying MBBS, and I will tell her about this branch, and I will tell her that she should do this." That
So
was so interesting.
yeah, so a student came to me last week, and she said that I've just finished NEET PG.
PG.
And NEET PG means
Yeah,
the
yeah,
entrance
entrance.
exam for the postgraduate in medicine. And she's like, I'm wondering what to do, and palliative care is one of the things on my list. Um, and I sat her down and spoke to her for 20 minutes. Now, at the end of the day, I don't know if she's going to take it or not. But the thing is that what is also important is to clear a lot of the myths around it. So, she had heard that there is a lot of burnout involved. She had heard that there is a lot of counseling involved. I would say burnout and counseling are some things that happen to anybody in any medical field.
That's right. Many people quit chosen branches. They take conventional chosen branches and they quit.
And this is one thing that I told her, was that today, if I attend a palliative care conference, there will be a session on self-care and burnout.
You don't have that in.
I don't know of any other
Absolutely.
specialty that addresses it.
So in healthcare, there is burnout, but one of the only branches that seems to look at it is probably, I don't know if psychiatry might be doing it, and mental health does it, and
Mental health does it,
and
and
palliative
palliative care
medicine. So
does it.
two branches that do
So
that.
there are just a
Amazing.
handful of branches that do that. Okay, uh, TLDR. What is palliative care for you?
For me, it's about addressing people who are suffering and using science, because that's where I'm coming from, and to make a difference in their quality of lives. and have people who give me the same rush that that man gave me, the one I had given that block, and he says, ah, I feel better. I want that. So I want palliative care to do that for every person that we interact with.
That's amazing. I think for me, palliative care is, it's personal. You get to choose, you get to decide what happens to your body, what happens to your body, even if you cannot make those choices at that point of time. You get to decide well ahead of time. You get to have a say in your. I mean, you don't always have a say if a disease comes to you or a disease befalls you, but at least you get to have a say in how you will manage that disease, or how the medical community will manage that disease for you, what kind of care you will get, what kind of treatment you will get.
Superb. So that sums up the instant 2 minute Maggie effect of relief and a long term plan of arranging the
Yeah,
kitchen, you know. So
yeah,
it's beautiful. Yeah.
yeah, yeah.
So thanks, Smriti. And I hope that we're able to reach more people and talk about palliative medicine, palliative care, and healthcare, because I think the focus of what we're trying to do is
That we live well. That we live well.
all right.
Thank you.
Thanks.